candidate.
Hello.
Hello. Could you
I,
ask control, please?
sir, I have
25 year.
requested.
Yes, thank you. 25-year-old female patient presented with acute right lower abdominal pain. Go
Okay,
on.
these are real MRI T2 weighted images. Sir, I think, yeah, I have some problem with the.
Go on.
Okay, I am scrolling. Okay, these are MRI T2 weighted axial images of 25-year-old female patient having history of acute abdominal pain. I can appreciate that uterus shows intrauterine gestational sac with the fetus
Okay.
in its endometrial canal with anterior growing placenta. Also, I can appreciate that there is hyperintense lesion involving the right adnexa. Um,
Mhm.
this shows internal low intensity areas showing shading effects, and also there is also internal cystic area within this cyst within this cyst. I am looking for any fluid in the surrounding tissues. Sorry, this is, I think this is a T1 weighted image. Yeah, this is
Yes.
T1 because spinal canal. I can appreciate that. Yes, if it's, yeah. And also
And
the
see,
amniotic fluid is
one
also,
second. 1 second. And the subcutaneous fat is very bright, very
yeah,
bright. Okay.
yeah.
In the T2, my colleagues, in the T2, the fat is less bright than T1. Less bright. Okay. Go on.
Yeah,
Yes, go on.
also muscles are less hypointense as compared to T2. So there is a hyperintense T1 weighted cystic lesion showing internal cystic area in the region of the likely in the region of the right adnexa as the ovary is lifted due to gravity uterus.
Mhm.
Um, hmm, it show there is it shows internal hypointense components. Um, I am looking for the I cannot see any free fluid in the peritoneal cavity. Um, yeah,
Concentrate on some. See, doctors, you make a very easy mistake. Why? You find a pathology in the right side. Don't leave it. Try to give some details and some differential
okay,
before you leave it.
okay,
Mm.
yeah, okay. Okay, so the hyperintense lesion in the right and neck side could represent hemorrhagic
Or
cyst,
or
or it could represent ectopic pregnancy or
or
torsion, or it could
yes.
be some dermoid cyst
So
with fat
what is the
component.
next sequence? What is the
Sir,
next
I
sequence?
will like to see the fat sat images to
Yes. Excellent.
look for fat suppression. Okay, this in the fat suppression images, I think there are a few areas which show internal suppression of the internal fatty component,
Okay.
and also hypointense areas are also there. So likely this is dermite. So I am looking for the Taurian evidence of the ovarian Taurian. I think this is the tubular thing. This looks like a pedicle. Uh,
Yes. What else?
so
Mm.
likely this is, I will like to see this on the coronal and other imaging for um, yeah,
What do you think? What do you think?
yeah, this is likely the in this gravid patient, the right adnexal lesion showing a few areas of suppression of the fat, likely these are dermoid, and I am as there is evidence of pedicle, so likely this is the torian. It is causing torian of the right ovary. So as this is
Excellent.
emergency, I will pick up my phone and will inform the referring physician to suggest urgent referral to the gynecologist for further management in this case. Also, I think there is.
Mhm. Thank you, doctor. You did very, very well. Also, according to the size is very large. See, very large. And the history of acute sudden right iliac pain, all of these are very suggestive signs of ovarian rupture. Okay, my colleagues, take care in any pregnancy MRI to rule out, especially placenta previa, because it is very important and it comes very easy. You can diagnose it very easy. See the placenta here. Okay. Thank you, doctor, so much. And my advice to all of you, when you find a pathology, concentrate in it first, and then go to the other finding, go to the other negatives. Like next candidate.
Thank you, sir.
Hello, doctor.
Hello.
Yes, hello.
Request control. 55-year-old male patient presented with weight loss.
Okay, I'm presented with axial cuts, CT abdomen pelvis for a 25 years old patient presented with weight loss.
Mhm.
Let me try to scroll.
Leave. Yes. One second.
Okay.
Use the arms. Use the arms. No. See. Leave. Use the arm.
Okay. Sorry, doctor, I can't scroll by myself.
In the exam, see, leave the mouse 1 second. Leave 1 second. This toolbar is here. Okay. By the way, and it is very easy. You can catch the toolbar like this and go. See? Go. One second. This is the toolbar. Yeah.
Okay.
Scroll.
I'm presented with axial CT abdomen pelvis portovenous phase for a female patient, the 55 male patient presented with weight loss. I would like to take check of the whole sequences, then I will give my comment. So
Okay, leave the mouse.
sorry,
I will help you.
sorry, doctor, could you scroll for me? I will give you control back. Yes, this is the lower chest cuts, which appear unremarkable for me. So,
My colleagues, 1 second. My advice to all of you, if in case of any technical problem, you have one invigilator beside you. Tell him and tell the examiner. Okay? They will help you. And you have IT, many IT person in all venues. In case, and it is very rare, you face something and you feel that it was unfair, it impacted your performance, immediately make IR within inside the venue. It's very important. It is your right. I'm just telling you some of the rules of RCR examination. Very important to do one paper. And if you have internet, open your account on RCR and do another complaint, because the IR only is within 48 hours, valid within only 48. Try also to take a photo from the paper, the IR paper that you made in the exam venue is very important evidence. Okay, my colleagues, go on.
Okay. So till now, I can see there's an umbilical hernia with fat stranding, and I can see that. I think this is incidental finding. Yeah, the umbilical hernia with some fat stranding. And there is some sigmoid divertically without any complication.
What else?
I can see there's some thickening here in the stomach wall,
Excellent.
focal wall thickening,
Okay, excellent.
involving the anterior and posterior wall. I would like to check if there is any surrounding enlarged lymph nodes.
Okay. What else?
What else? Okay, I would like to go down. This is
What's your diagnosis, doctor? Give me definition.
As a patient is complaining of weight loss, I'm suspecting that this is a short segment of focal wall thickening. I'm suspecting this might be malignant. I would like to check the presence of lymph node.
Doctor, one
Sorry.
second. Is this focal? Mural, not focal.
Sorry,
Focal
mural.
means something like this. But see here, this is a mural thickening along this curvature. Okay? So,
Okay. Yes, I still see this thickening on the wall of the stomach with no significant lymphadenopathy seen.
which part?
There's
Which part of this?
this is the greater this is the body of the stomach.
Yes, greater and lesser curvature. Okay.
Greater and lesser curvature, yeah.
What is this? What is this?
This is
Are you sure? No. Are you sure there are no lymphadenopathy?
Yeah, it wasn't clear for me before, yeah, but I think this is lymph nodes, yeah.
Give me a final diagnosis, please.
So I'm suspecting this is malignant lesion.
What is the commonest route of metastasis for stomach cancer?
Sorry, doctor, what's your question again?
Tell me the commonest routes of metastasis for cancer stomach.
Lymphatic spread and for the adjacent structure. The adjacent structure.
What about the peritoneum? Stomach is one of the most common. Hello? Could you listen me?
Yes, sorry, doctor. Yes.
Yeah. Stomach is one of the most common, or cancer stomach is one of the most common causes of peritoneal metastasis, peritoneal carcinomatosis. Okay.
Yeah.
Second is liver metastasis, blood-borne liver metastasis. What to happen? Stomach spread some peritoneal deposits. Okay, but not in this case, by the way. This peritoneal deposit may go and fill the old peritoneum and go down in females, especially in females, and affecting both ovaries. If the peritoneal metastasis affecting both ovaries, what is the name of this condition?
Krokenberg.
So, my colleagues, Krokenberg, mainly not the origin from the both ovaries. No, Krokenberg is a transperitoneal metastasis to, not from, to both ovaries. This is very important. Thank you, doctor, so much. My colleagues, my advice for you to look at the stomach, one of the tricky organs in the CT abdomen, then to the pancreas. Very important. Pancreas, one of the organs that can be tricky. Then to the other bowels. Okay, my colleagues. Thank you, doctor, so much. It was cancer stomach case associated with.
Thank you, doctor.
Welcome, next candidate.
Assalamu alaikum.
Salam. Request control, doctor, please.
Sorry, I'm on my phone, on my
Okay,
mobile.
for 76-year-old male patient complaining of chronic constipation.
Okay, I have been presented with axial images CT scan for elderly patient with history of chronic constipation. This study was done with oral contrast and rectal contrast. I can see that there is a large filling defect noted within the rectum, which could represent impaction of the feces. However, I also noticed that there is thickening of the mural thickening involving the cecum and the proximal part
Excellent.
of the ascending colon. I want
Excellent.
to review the rest of the colon to see if there is how long the segment that involved within the segment, and I want to check if there is any fat stranding, lymph node enlargement, peri-thickening, or if there is any free fluid ascites within the pelvis of this patient. I can see that the descending colon appears collapsed. Also, the sigmoid colon appears collapsed, and the small bowel appears within normal diameter. In my routine practice, I want to check if there is any other sequence for this patient, and also
What else,
I want
doctor? What
yes
else? What else in this?
finding.
Hmm.
Yeah, I want to review the right groin area. Sorry, someone put it in the chat. I can see that there is a hypodense, well-defined lesion seen anterior to the urinary bladder, and in my routine practice, I will measure the Hounsfield unit of this lesion. If it is minus up to 100, I will consider this as a fatty mass lesion, and I want to see the MPR projection for this study, such as the coronal and sagittal. And also in the femoral area, I can see that there is enlargement of the femoral vessels on the right side, which could represent some sort of aneurysm or, here at this cut
Thank
at
you,
the
doctor, so
femoral
much.
area.
Thank you. This is a case of pelvic lipoma, large lipoma, okay, and cecal carcinoma, cecal and ascending colon.
Yeah.
Take care from my colleague. Take care. I told you many times before. If there are any large obvious pathology, sure there are another less large, less visible pathology. Sure. Okay. This type of examination, the examiner wants to examine you if you have a satisfaction of search or not. Thank you, doctor, so much. Next candidate.
Thank you.
Next candidate.
Assalamu alaikum, sir.
Salam. Request control, please. Request control.
Yes, sir. I'm requesting.
No, nothing. Request
I
again,
think
please.
there's some problem with internet. Sir, I have requested.
Thank you. This patient
This
presented
is,
with headache, no history of surgery. Go on.
okay. This is MRI brain T1 weighted images with post-contrast study in which mouse is not scrolling. In which I can see that there is a significant enhancement of meninges. Sir, I cannot scroll the images. Can you please scroll for me? I think there is some net problem here. Okay, there is a significant enhancement and thickening of the meninges noted with the evidence of the enhancement of the tentorial leaflets also. I would, however, I cannot see any focal lesion which are showing any significant area of other area of enhancement. There is also mild effacement of the sulci and gyra that may represent increased enhancement of the venous sinuses, predominantly at the transverse sinuses. I would like to compare my findings on the sagittal images.
See, there are some noise in your voice. Please, yani, be away a little bit from the mic. Okay.
Oh, sir, internet connection is not stable. Actually, there is some storm sort of thing.
No problem, no problem. Okay, what's
sir,
your differential diagnosis?
Intense enhancement. Sir, I would like to keep the differential of intracranial hypotension versus
excellent.
Sinus thrombosis. Hello?
Yes, excellent. What sequence
Sir,
do
I
you
would
want?
like to see sagittal. Okay, sir. On the sagittal images, I can see that there is mild tonsillar herniation. Fullness of the posterior fossa is seen. No definite herniation is seen, but there is some fullness of the, and there is also straightening of the tentorium noted. So these findings are likely representing intracranial hypotension.
Thank you, doctor, so much. You did very well. It's a case of intracranial hypotension. Okay, why? This is a post-contrast. See my colleague, diffuse, homogeneous, uniform, pachymeningeal enhancement. This is the most important buzzword in this case. As I told you before, every case has some buzzword. If you told the examiner most of them, he will be happy. Okay, see, diffuse, uniform, pachymeningeal enhancement. Plus, see here, marked effacement of the prepontine system and collapsing or reduced size of the ventricular system. Then she asked for the sagittal for more confirmation. Thank you, doctor, so much. Hypotension, intracranial hypotension, very common after surgery, after spinal surgery, after acupuncture, or sometimes from other causes. Anyway, thank you, doctor. You did very well. Next candidate.
Yes, sir.
Could you please control this? Request control.
Should I request remote control?
Yes, request immediately.
Yes. Okay. Okay, so these are the MRI images.
This patient,
axial section.
This patient has menorrhagia.
Okay. So I'm presented with MRI pelvis axial section T1 weighted images.
Okay.
First, I like to go through the images, then I will start describing my findings. Okay, I can see that uterus is enlarged in size and appears to have heterogeneous ecotexture. I cannot see the normal endometrium and myometrium on this T1 weighted sequence. However, I can see that there is some perimetrial fat straining, and I'm looking if there are any enlarged lymph nodes. I can see that there are enlarged lymph nodes on the right side along the internal iliac vessels.
One question. Could you think that T1 is the ideal sequence to evaluate?
No, I want to see on T2 and post-contrast sequences to look for the endometrium.
If you didn't ask, the examiner will not give you. Next, scroll, please.
Okay, so this is a T2 weighted image.
Yes.
There, I can see that there is enlargement of the endometrial canal and with distortion of the endometrial cavity with the hypointense mass lesion, and
Hmm.
there is also
Wait,
heterogeneous myometrium with loss of the junctional zone,
doctor,
and there
where is the exact location of this mass? Where?
endometrium,
Sure,
central endometrium. I
you
want to
ask,
see in the sagittal as well.
see, because you ask for the incorrect sequence, not sequence, any plane. You should from the beginning, doctor, show me the sagittal T2. So this is the sagittal
Okay,
T2.
yes, I want to see sagittal T2.
My colleagues,
Okay, I can
please,
see
in
that this is,
pelvis,
yeah,
sagittal T2, in female
yes,
pelvis,
sagittal.
especially high resolution, and in rectal also, in rectal carcinoma, T2 high resolution, but axial is very critical, very important, very conclusive. Go on.
Okay, so I can see that there is a, mass lesion seen in the region of the cervix, which is hypointense on the T2 weighted images, and I can see that the endometrium is normal, and there is a widening of the junctional zone with internal cystic areas, which is concerning for adenomyosis. Um, it's not scrolling. Yeah. So some mass lesion is seen, thickening in the region of cervix. Um, and a cyst is seen in the adnexa, which is likely a benign cyst. And I want to see the post-contrast images, sagittal section, for to look for the enhancement of this cervical region mass lesion.
What's your differential within يعني you take 3 sequence till now. At least after
Yes.
first,
Yes.
see, one second. My colleagues, at least after you see one sequence, full sequence, you tell the examiner something about what is in your mind. If I am
Yes.
in your situation, after the first sequence, I will give him 3 differential diagnoses. After the second, I will exclude one. After the third, at least I will put one differential diagnosis at top and searching for complication, metastasis, lymph nodes, extension. This is the style, and this is what the examiner wants from you. Again, after the first, you see the first sequence, give 3 differential diagnoses, 3 related. Then ask for another sequence. After you finish the second sequence, exclude at least one of the 3. After the third, speak in more details about one most possible diagnosis, including its complication, extension, lymph node, or metastasis, or infiltration. So tell me, what is in your mind about these 3 sequences?
Yes. So, yes, I can see the enlargement of the uterus and enlargement of the junctional zone with internal cystic areas seen in the region of the junctional zone. And
1 second,
keeping in
doctor.
mind the history of menorrhagia. Yes.
No, doctor, see, you describe all these things before. Don't repeat. Don't repeat. After 3 sequence, at
Yes.
least you
I am
should tell
concerned
me
about cervical.
yes, yes.
Yes, I'm concerned about the cervical mass, and I like to see it on the post-contrast images.
Doctor, you hear me well? My voice is clear? Hello?
Yes.
Doctor, see, you
Yes, I can hear you.
describe,
Can you hear me?
you described a cervical mass. So after 3
Yes,
sequence, at
it's
least you should tell me, doctor, I'm concerned about cervical carcinoma. Frankly,
cervical mass. Yes.
frankly, doctor, I'm concerned about, and what is this? What's your concern here or professional diagnosis here?
Oh, cervical mass.
Here, cervical mass. And what
Yes.
about this? What's your concern?
Uterine
What's your
adenomyosis. Uterine adenomyosis.
okay? Like this, the discussion must be in this style. After you first you see, then you describe some details, then you should tell some differential. It is very annoying to the examiner to listen again and again the same details. He went from you to build gradually, no problem, gradually your differential diagnosis, and he is waiting the minute or the second that you are talking about 1, 2, 3. This is my differential diagnosis. This is what he wants. Okay?
Okay.
Go. Hello?
Yes, hello.
Yes. So your one second. Your differential diagnosis is cervical carcinoma and adenomyosis. Do you want to
Yes.
do to exclude anything?
Yes, I want to see the post-contrast images and also the parametrial invasion, which I think there is parametrial invasion and fat stranding noted in the parametrium location along the
What else?
fat,
What else?
and also
There are
enlarged
there are
nodes
ve-
and
okay. There are very important pathology or complication you must exclude.
bones also I want to see, and
See, this is a cervical carcinoma. You suspect
yes,
there are parametrial invasion, and this is maybe
yes,
correct.
I suspect
No,
parametrial
maybe correct.
invasion
Okay.
and
So,
adjacent structures.
one second. When we suspect a parametrial invasion, we should tell the examiner,
Yes,
we should rule out any hydronephron.
hydronephrosis, because it
Hydronephron.
can encase the ureter. Yes,
Yes, it is very important. Okay, very, very important. The examiner is searching in your brain about more than what beyond the pelvis MRI. So if I am in your situation, oh doctor, at least I will do one abdominal ultrasound. At least. Why? Rule out
yes,
hydronephron. The examiner
hydronephrosis.
will be very happy. Okay. Okay, you are correct.
Yeah,
You want a post contrast rule invasion or what else? What else? Okay, but this is not life saving for the examiner.
yes,
This is not life saving. What is life saving is hydronephrosis.
hydronephrosis. Yes,
Thank you, doctor, so much. My colleagues take care of double pathology. Don't hesitate. When you suspect, tell the examiner, oh, doctor, there are a mass, this is, and describe, and then, doctor, my differential is cervical carcinoma. There are market thickening of diffuse thickening of the this transitional zone, okay, and the containing cystic changes, and I'm worried about, sorry, junctional zone. I'm worried about adenomyosis. Okay, don't be afraid. Many cases, the examiner bring double pathology. Thank you, doctor, so much. Next candidate.
Good afternoon, doctor.
Good afternoon. Ask for control, please.
Yes, I've asked. Okay.
60-year-old male patient complaining of abdominal pain. Go on.
So this is MRI axial cuts of T2 fat saturated images. Trying to scroll. Okay. So I would like to scroll from the top to the bottom images to the, and then give my diagnosis. I'm in the first instance more about and okay. The images are jumping. There is an intimal flap in the aorta that I could see. Okay, sorry, doctor. The images are jumping again. Okay, doctor, are you moving?
No, at all.
Okay. So it's jumping. Okay, so I would like to go through this sections. The abdominal sections. Okay. Okay. So I can see that there is intrahepatic biliary radical dilatation with significant dilatation of the CBD.
Yes.
I'm trying to trace the CBD down to the ampullary region. There is no sizable mass at the distal CBD region or around at the head of the pancreas, and there is no intraductal calculi. However, I can. Okay, this is about. I'm checking the gallbladder. There is no calculi, no cholecystitis. The pancreas appears atrophic with prominent pancreatic duct. Okay. So I would like to check the post-contrast images for to rule out any pancreatic mass lesion.
What else?
T1 post-contrast.
Okay. Exams.
Okay. So this is
1 second.
okay.
A2, there are no post contrast, only conventional MRI. Okay.
Okay.
What's happening?
Okay, the stomach appears grossly dilated.
Easy. What is your finding from the axial? Tell me again.
The
What did you
aortic,
find?
okay, so there are two main findings. The aortic dissection flap involving the distal thoracic descending aorta
Okay.
and the biliary dilatation. Okay.
1 second, 1 second. Can you
Okay.
diagnose aortic dissection only like this? It may it may be a flap.
It might be
artifact.
yeah. Yes. Might be artifactual.
Half.
Yes.
Okay.
Okay.
Second. What did you find here? What did you
So
find?
there is the gross intrahepatic biliary dilatation.
Okay, excellent.
So I would like to check and
1
the
second.
CBD dilatation. Okay.
Okay, and what else?
Yeah, there is.
What is the name of this one? What? Okay.
The pancreatic duct dilatation also, but mild.
Yes. So you have
so this is double duct dilatation. Yes, double
sign.
duct.
Okay.
Yeah.
Okay.
Double
duct. What is the point of cutoff? Transition point. Where?
At the ampullary region.
Yes. Okay. So what's your differential diagnosis? What's your differential?
Periampullary carcinoma or neoplastic process.
Okay. Or ampullary too. Very easy.
Okay.
See, my colleague, some cases came like this, especially startup case. Very easy, very direct. But most of us are expecting the worst scenario. So we are insinuating ourselves in the realities. If I am in your place, I will do like this. I will see first. This is very obvious. So I will describe all finding about the biliary dilatation, and I will check here. Oh, this one. This is pancreatic duct dilatation. So, doctor, we are dealing about with double duct sign. I am requesting post contrast, whatever you request. Then, doctor, I have a doubt about this. Is this to aortic dissection or just artifact? Almost he will tell you, don't worry about it. Why? because if he let you to talk about it, he is responsible about يعني about wasting time in this non-significant pathology.
Okay.
See, so when the examiner guide you, he almost he 100% guide you in the correct pathology. Okay, my colleagues, this is a double duct sign. We then give me differential diagnosis, ambulatory or pre-ambulatory carcinoma and obstructing stone. Thank you, doctor, so much. You did very well.
Assalamu alaikum, sir.
Request control, please.
So, what's the history, please?
Thank you. Thank you for requesting the history. If the examiner didn't tell you a history, ask. And if you in the middle of the exam want more data, like if they have fever, have he have any congenital family history, ask. Sometimes the examiner is waiting you to ask.
Okay, so 65 years.
Year old female patient, abdominal pain and vomiting.
Okay, pain, vomiting. So this is axial CT with axial CT with contrast seen in the body.
One second. Leave the mouse. Leave the mouse. Leave the mouse. Use the arrow.
Okay. Sir, there's a lag.
Okay.
So, sir, will you scroll?
Yeah.
Okay, thank you. So I'm looking at the images. Epigastric pain and vomiting. Okay. So I can see the contrast in the ball, and there is some thickening at the this is the, I think this is the large ball in the region of the descending colon. Can I please see the coronal images post contrast?
See. Don't ask. You didn't tell me any details. So tell me some details, and then I will give you. Like you move up, move up, and this is a connection of this bowel. I see. This is the connection.
Yes, sir. So this is the duodenum.
Yes, this is a connection.
Yeah. So this is there is thickening of the duodenal wall, but I cannot see any holdup of contrast, oral contrast, and I cannot see the contrast passing through. No, okay. So it has gone through. Yes, it has gone through. There is no obstruction. However, there is diffuse wall thickening of the duodenum.
What's your differential diagnosis?
Sir, he has pain and vomiting. So this could be, it could be the excess of, so I'm looking at the coronal images. There is diffuse thickening, I can see. I'm looking at the rest of the ball.
First, the doctor, give me the other details here. Is this infiltrating something? This benign, aggressive? What? There are many details.
Sir, it looks aggressive. It looks aggressive. Yeah, sir.
Give me differential diagnosis.
Sir, it could be a malignancy, as it's aggressive and sorry.
Okay. What type of malignancy? See, doctor, is this associated with dilatation or stenosis? What do you say?
So there is mild dilatation. There is no stenosis.
Okay. Which type? GIT malignancy? Is that
Sir,
not associated?
Yes, sir, it could be a lymphoma.
Yes, very easy.
Sir.
Okay. Yeah. So this is a case of duodenal lymphoma.
Yeah. Yes.
Okay.
Sir.
So
yes, sir.
you should what you should look for.
Sir, I'm looking at any lymph node enlargement. I'm looking at the liver for any metastasis. I would like to look at the bones as well for metastasis of in
No, no, no,
bones.
no. See. No, no. Doctor, I will see the liver. So he sees the liver. Oh, doctor,
Yes, sir.
there are not any condition. Okay.
Yes, sir.
Don't,
Yes, sir.
don't enumerate something. Okay.
Okay.
I
Okay.
will measure the spleen, rule splenomegaly. Okay.
Yes, sir. Yes,
Look
sir.
here. What happened here?
Yeah, so sir, this looks like there is enlargement of the left adrenal gland.
Enlargement or mass. There's a big
It's a
difference.
mass. Sir, it's a deposit. It's a mass.
Maybe deposit, maybe something
Yeah.
else.
Yeah, it
So,
could be. Yeah. Yes, sir.
what should
It
you
could
do
be.
to differentiate deposits from the adenoma?
Sir, the in phase and out of phase
RNCT doctors.
MRI.
What
Yeah.
technique? No.
Oh,
NCT. What technique to differentiate between suprarenal adenoma and suprarenal metastasis?
sir, post contrast.
Okay. After how many minutes?
For adrenal. Sir, I cannot think of it now.
15 minutes.
15
15
minutes. Yeah.
minutes wash out. This is very, my colleagues, you know, this is very important. 15 minutes. And you will measure either the relative or absolute wash out, either it is
Yeah.
40% or 60%. See, at least you should tell the examiner, doctor, I will do 15-minute delayed post contrast
Right.
for the suprarenal. Even if you didn't know accurately the percentage, okay, it is maybe acceptable, but at least we should tell
Okay.
the type, the technique. Second point, there are focal hepatic hypoenhanced here. But by
Yes,
the way,
sir.
this is the lipoma.
Yeah, it
Thank
looks
you,
like a
doctor,
lymphoma.
so much.
Thank you, sir. Thank you.
This is the duodenal lymphoma of the second and the third part of the duodenum, associated with aneurysmal dilatation. And this is very important buzzword, aneurysmal dilatation. Why? Because it infiltrates the submucosal and mural nervous nervous plexus. Okay, so and subsequently cause aneurysmal dilatation. Next candidate.
Assalamu alaikum.
Islam. Doctor, this patient
So these
has abdominal pain. Could you request control, please?
sorry, sir, I cannot control you. I'm from Mumbai.
Abdominal pain.
These are axial sections from CT, thorax, and abdomen. It is non-contrast CT in which I can see that mediastinal window, cardiomediastinal contour is unremarkable. No significantly enlarged lymph node seen.
Are you sure?
Few enlarged lymph nodes are noted. Yes, in the right paratracheal region and bilateral hilar region. Yes.
No, don't worry about it. What else?
There is some hypodense lesion in right, hypodense multiple lesion in right axillary region. Yes, lesion. It is soft tissue. It can be enlarged lymph node.
Yes.
However, I will check other sequences as well.
What else?
Multiple lymph nodes. I think these are in large lymph nodes present. They are on liver. There are multiple hyperdense foci are noted.
Excellent. Hyperdense or hypodense?
Hypodense foci randomly distributed in both lobes. Our liver margins appear smooth. No evidence of cirrhosis. I will check the left lobe of liver to rule out any cirrhosis or underlying liver pathology. However, I could not find any liver parenchymal disease. So these were multiple hyperdense foci in liver could be metastatic deposits. with enlarged right
where do you think is a prime?
primary can be in breast. So there is a large speculated mass is noted in right breast with the parenchymal distortion and so overlying skin thickening. So most likely diagnosis is right breast malignancy with the metastatic deposits in liver and right malignant lymph nodes. I will next convey my findings to referring physician. And if the patient is already a known case, then I will advise metastatic workup as well as bone scan. And if not, then breast mass biopsy as well as mammogram and other staging workup will be advised.
What else?
I will rule out other lymph nodes in intermembrane vein region.
What else? Don't worry about other lymph.
I will also check the left breast as well as left axilla and also check the mediastinal window.
One second.
Lung
What
window.
is this?
Lung window.
Very
yes,
critical.
lung window. Yes.
And as we said before, and the Dr. Ismail told many times, in most of the malignancy cases, rule out pulmonary thromboembolism is very commonly associated.
Okay.
Second. One second. What is this?
This is a spine. I will check on the bone window to rule out osseous deposit.
So you should tell me, doctor, I want to window. Doctor, I want to check bone metastasis. Almost the examiner will tell you, okay, thank you, don't worry about it. If he gives you, sure there are something. My colleague, thank you, doctor, you did very well, but listen to me in 3 notes. See, my colleagues, I remark that most of you is concentrating to talk about negatives. No, please try to change your attitude. Your role here in FR, because the exam even is limited time, to pick up any pathology, even subtle pathology. This is your role. For example, if you told me about this and about this skin thickening, see, or here is not really clear too much. Despite the density of tissue here is more denser than here. Okay, and this almost I will give you a very high, and then ask for contrast. When you ask for another sequence, look again for your area of interest. The area is this. Please mute yourself, my colleagues. Please.
Yes.
Sir, it was my turn.
Okay. The area is this one. Is this one, my colleague? Okay, so look if there are bone erosion, if there are another related, see, there are another lymph nodes, and then look at the supraclavicular region, and then what is this? This is a mass. This is skin thickening. See, this is a film edge, and this is very common scenario. You must get one film edge in the exam. Then the metastasis of liver. So this is a left breast cancer with liver metastasis. And then ask for sagittal. I think sagittal, routinely ask for sagittal in all examination. Routinely. It's very important to rule metastasis, to rule in brain the 5 points that we talk about, in the pelvis, to rule also extension. Sagittal is very important. Why? Because you see the bone. Okay, my colleagues. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Salam. Request control, please.
Yes.
This patient presented with shortness of breath.
Shortness. Sir, I'm okay. Okay, sir. Sir, I'm provided with CT scan axial images. It's coronary, it's angiogram, which is lower limb angiogram as well as the lower abdominal cut. I want to scroll from top to bottom. Okay, sir. These are probably venous images, sorry, arterial images. Here I can appreciate there is a, sir, filling defect. Yes. Yes, sir. So there's a filling defect identified in the right popliteal vein.
Okay.
Sir, I want to see the extent of this filling defect. Sir. Yes, sir. Sir, it is seen to be extending from popliteal to femoral vein as well. And
Do you think, see, doctor, do you think this is
yes,
the ideal phase to rule out
yes,
or to assess the
yes, sir.
extension?
Yes, sir. It's arterial phase, and in which there I can appreciate this a thrombus. So I also want to confirm on the venous phase to further confirm the this filling defect.
Thank you, doctor, so much. This is an
Yes.
observation film. Okay.
Yes.
And there are a right popliteal or popliteal-femoral, whatever swear. Thank you. Lower third. Leave the nose leaf.
Yes.
Lower part or popliteal-femoral junction here.
Yes.
Filling defect. Doctor, it is
Yes.
very difficult. Okay, compare.
Yes.
In musculoskeletal and arteries or vascular examinations,
Yes.
even compare. Regularly compare. All this vascular examinations, investigation, you are given both. There are filling defect here. Go up,
Yes.
up. Really, I can't judge the extent, but at least you pick up the pathology, and it is related to the patient complaint in the form of shortness of breath.
Yes.
Thank you, doctor,
Sure.
so much. What is your next step?
Sir, second, I will check on the venous and MIP images about the
What
this.
else? What
Sir,
else?
D-dimers and anticoagulation state of the patient, also history of the
What
patient.
else?
Sir, then pulmonary embolism. I have to exclude the pulmonary embolism and thrombosis.
Thank
It
you,
may
doctor.
lead to
This is the point. This is the point. We have DVT and shortness of breath. So, if the patient is still in your radiology department, do CT angio, pulmonary angio. Okay? Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Dr. Amiga, how many candidates remaining?
She's the last one, Dr. Rami.
Okay. Request control, please.
Sorry, sir, I can't today. Sorry for today.
Okay. This patient is 45-year-old female patient with incidental brain finding in the CT.
These are CT brain axial section of a 45 years old female, plain images showing the region of base of the skull. I will take a moment to scroll. In the first glance, I could not appreciate any significant finding. Some hyperdensity is seen in the basilar artery region, which I would like to correlate with the history of the patient. There is a normal bilateral basal ganglia, white matter, gray matter. There is, sir, can I see the CP angles on both sides?
Don't worry about it.
Okay.
What is your next step?
Sir, I would like to know the history of the patient. If there is sudden onset of any symptoms, I have seen some hyperdensity in the basilar artery region. It could be projectional, or in the post-contrast images, it is showing a normal enhancement. So
One second, doctor. Because I am kind examiner, I give you this. But if you didn't ask, the examiner will never give you the postcard. And he will let you talk, and finish the case in another way. Okay? So
Okay.
always request. Always request.
Okay. So there is some hypodensity in the region of medulla. Sir, can I see some sagittal sequence? I can see that there's some hypodensity in this region, some crowding in the region of medulla. Fourth ventricle looks obliterated. It is not visualized on this part. No, it is normally seen, and there was no hydrocephalus above it.
Doctor, follow the fourth ventricle, please.
Sir, there is some there's some hyperdensity seen along the right sigmoid sinus, transverse sinus.
Doctor, look here. What happened?
This area is looking crowded, and
What is
loss
this?
of
Doctor, what is this?
this hyperdensity.
Where?
It is in the floor, in the lowermost part of the, in the Vermian roof.
Okay. But this is hyperdensity or hyper enhancement?
It is hyper enhancement. It was not there on the plain one.
Okay. What do you want next? What's your differential?
Sir, my differential is that it could be any focus of, it is an enhancing focus. So any neurocysticercosis, any stage in which it is showing an enhancement, there's a hypointensity adjacent to it as well. Other other possibilities can be some metastatic deposit or any small mass lesion. I would like.
Doctor, do you think neurocysticercosis will avidly enhance it like this? And metastasis will be single like this?
No.
Give me another differential. See?
This
What
is,
is
oh, sir, this
What
is related to the vessel, and it is some aneurysm. It is aneurysmal dilatation, and it is in the region of either ICA or PICA.
Very excellent. So,
So it is likely coming from, where is it in this? These are,
see?
Yes, this is it. Sir, I think this is PICA.
Okay. So finally, give me the final differential diagnosis.
So it is pica aneurysm. I would like to measure the its maximum dimension, its neck, any associated intracerebral bleed associated with it, which was not present, any subarachnoid bleed which was not present. I would also like to take history. If patient has any such aneurysmal dilatation in the past or known clipping, then she should be followed up regularly. But this area has a very little adjacent space to spread, so it can be lead to neural compression. So it needs to be urgently, findings need to be urgently communicated.
Thank you, doctor, so much. My colleagues, take care. When you find nothing, ask for others. Ask for post contrast. The examiner may give you. If he didn't give you, search again, you will find the result. This is a post contrast. There are hyper enhancing, homogeneously avid enhancing focus. Then MRI done and MRA, we find this. Okay, then what is this? This is a digital subtraction. This is angiography. Okay, digital subtraction. Okay, why? This is not a CT angio or MRI. Okay, and then this is the 3D. I think this is the MRA. We find this dilatation, aneurysm of the left bike. Thank you, doctor, so much. Dr. Amiga.
Thank you so much, sir.
Yes, Dr. Rami.
Are you ready?
Yes, sure.
I will give you one case. Okay.
Okay. I'm provided with contrast enhanced CT abdomen, eggshell cuts, arterial phase. I noticed that there is a thickening. I would like to go through the entire stack of images before commenting further. There are hypodense lesions noted in the liver. There was thickening in the esophagus. Fluid noted in the peritoneal cavity. Mm, okay, I'm going to the area of interest. The esophagus, I would like to see the esophagus. The lumen is thickened. There's wall thickening noted in the esophagus and multiple hypodense lesions noted in the liver uh, with some peripheral enhancement. And if the patient, I would like to know if the patient has a history of dysphagia. This could suggest esophageal malignancy. I would like to see the images if the coronal.
No dysphagia. No dysphagia.
Okay, I would like to see if the coronal images are available. I would like to see this on coronal images.
Look at the liver again.
Okay. So, in I think there is a rupture of there's rupture of one of the lesion, and
Maybe. What else?
if the
Look at the
patient
liver
has,
itself.
I would like to know if the patient has constitutional symptoms, if the patient has history of fever.
No. Look at the liver. What happens in the liver itself?
The liver, the surface appears to be scalloped, and I think there's scalloping of the surface and some irregularity. I
No
think
scalloping. See. No scalloping, but there are irregularities.
This is cirrhosis. I think the patient, yes,
Okay.
there is an enlargement of the left lobe of liver as well. So
Yes.
in the patient with cirrhosis, multiple hypodense lesion, I'm thinking of malignancy of hepatocellular carcinoma, as it
Okay.
could be complication in a cirrhotic patient. I would like to see other phases. I would like to see the delayed phases to see the contrast washout, and uh, if the lesions wash out in the delayed phases, okay, I'm provided with the
One second. This is which phases?
this is this is arterial phase. I think this is portal venous phase.
Yes. Do
Yes.
you think there are some washout here or no?
Yes,
In
there is
comparison?
washout. Yes,
Yeah.
there is
Okay.
washout. Lesions are
Okay.
showing washout in the portal venous phase. So, and one of the lesions has ruptured in the subcapsular region as well, with surrounding perihepatic fluid. So,
No. See. No rupture. Why? Because this is ascites, clear ascites, not hyperdense. Okay.
okay.
If I told you this is the venous phase, look at the hilum. What happened?
Uh, Okay, I noticed that there are some vessels,
Yes.
yes, prominent vascular channels noted.
Yeah.
So, in the setting of cirrhosis, these could be portovenous collaterals, and
Why this happened here? What happened here? What happened
I think
in
uh,
what happened here?
I think this is. I would like to see the portal vein. If it is not visible, then I think this is. Um,
Yes. Correct. Where
this
is the
is
portal vein?
yes, the portal vein is replaced by these channels. This is. Um, I'm not just the term is slipping off my mind.
No problem.
Main portal vein is replaced by these channels,
Okay,
which are present.
cavernous transformation.
Cavernous, yes. So this
But
is cavernous.
what happened for the main portal vein itself?
So I would like to see the portal vein to trace its course if there is any thrombus.
Yes.
Uh,
Could you see it?
okay, here's the splenic vein. Splenic vein is
Yes.
visible.
Up.
Superior miss.
Could you detect the portal vein here?
No. Yes,
So,
I think there is some thrombus formation in the portal vein, which has led to the cavernous
excellent.
transformation.
So conclude.
So in a
Please.
patient with cirrhosis, there is so this patient has cirrhosis with enlarged left lobe of liver, with multiple cavernous with thrombosis noted in the portal vein with cavernous transformation and multiple
multiple H
hypotension,
and the multiple
hypotension.
HCC.
Sorry.
Multiple and the multiple HCC.
Yes.
Correct.
Multiple. Yes. So I would convey my finding to the referring physician and would like to do a
One second. Why the esophagus is thickened? See?
So these are also
varices.
collaterals. Collaterals are noted here.
Varices. Okay.
Yes.
And there are other varices. Thank you, doctor, so much. Very well.
Yeah, thank you so much.
This is the case of multiple HCC on top of liver cirrhosis associated with portal vein thrombosis and cavernous transformation. Okay, this a case scenario of satisfaction of search. Thank you, doctor, so much for your attendance. Let's meet tomorrow at the same time. Tomorrow, after tomorrow, till Thursday. Study hard. You can do it for all of you. Good luck. Goodbye.
Sir, excuse me, sir. Hello.
Yes.
Sir, can I
Yes.
ask a question? Just a quick question.
Yes.
So, in case if in CT brain we don't find anything, can we ask directly to go for a contrast enhanced?
Yes, sure. Like this case, the previous case, really the plain CT didn't show any clue. So the only post contrast, and they did MRI, it was non-conclusive, just shows the same finding of post contrast CT. So see my colleague, ask. What will happen if the examiner didn't want to give you? He will answer you, no, I don't have. And by the way, these questions or asking or requesting will not make you lose any marks. Okay.
Okay, sir. Thank you so much.
Sure. Ask whatever you want. Ask nuclear, MRI, other plane, other sequence, anything. Okay, my colleagues.
Okay, thank you so much, sir.
Goodbye.